Good afternoon, one and all present here.
Just a second, ma'am. Just a second.
Okay.
Okay, you can start now.
Yeah. Good afternoon, sir. Good afternoon, one and all present here. Myself, Sarita Rathod, Assistant Professor, IT Department. On behalf of KJCIT IT Department, I welcome you for the session of the day 4, that is Contextual AI for Public Health of the AICD sponsored virtual STDP on leveraging artificial intelligence and data analytics for healthcare. Uh, Now I would like to introduce the speaker of the today's session, Dr. Tavpritesh Sethi, scientist, Department of Biotechnology, Government of India, Wellcome Trust, India Alliance, uh, and faculty, faculty. Sorry, sir, sorry. Uh, Sir's areas of expertise are IoT in healthcare, augmented reality in healthcare, medical image processing, artificial intelligence. His Google Scholar citation is 884, I10 index is 17, and H5 index is 12. Sir is physician scientist and the professor of computational biology at Indraprasth Institute of Information Technology, Delhi, India. He is a founding head of the Center of Excellence in Healthcare, IIT, Triple IT, Delhi. Faculty lead for the entrepreneurship, IIIT, Delhi. Sir is recipient of MIT TR35, India Innovators, WT DBT India Alliance Early Career Award. Uh, Sir has done the MBBS from the Government Medical College, Amritsar, India. Doctorate from the CSIR Institute of Genomics and Integrative Biology, New Delhi, India. He is a member of European Association of System Medicine. He is a lead of International Association of Systems and Networks Medicine, uh, Australasia Zone. Welcome, sir, and thank you for joining with us. We can now move ahead with our session. Over to you, Tavpritesh, sir.
Thank you so much. First of all, thank you so much. I would like to thank Dr. Radhika and all the organizers for inviting me for this talk. I'm very honored to be delivering this talk. So I'll just start presenting my screen. We'll dive right away into the session. And please let me know if you're able to see my screen. Just going to the presentation right now. Okay, so is everyone able to see my screen?
Yes, the screen is visible.
All right. So
Yes.
I believe that the presentation is also visible, right? It's contextual AI for public health.
Right. Yeah.
Yes, sir.
Thank you so much. So we are all set. So it's a 2-hour session. The way we will carry out the session, it's both a session about what is contextual AI. We'll start with what actually AI is, what are the different forms of AI, and then finally moving on to contextual AI. And then at the end of about an hour, we will take a short break of 7 to 10 minutes, in which you can actually go back and look up the next session's material, which will be a hands-on. I don't think we'll be able to do a hands-on because we are meeting virtually. But what we will do is I'll walk you through the hands-on on a contextual AI tool that we have developed in our lab in-house. It's called Visor. All right. So the session is in 2 parts, both scientific, theoretical, and then practical. All right. So that's where we basically will start. So I think, yeah, so my personal context has already been given. I would not repeat it. The only point that I would like to make here is that my journey in healthcare AI has been very exciting from an interdisciplinary perspective. So the last 15 years or so I've spent in combining medical knowledge and understanding with computer science to basically create solutions that that doctors can use. So I feel very strong and I feel very strongly and I'm very passionate about solutions that can come from computer science and can be used in real clinical and public health settings. So with that background, I work at currently I'm working at IIIT Delhi. So we are a relatively young institute, about 12 years old now, and we are very rapidly expanding. We started with we are a Delhi state government institute, and in the last 12 years we have expanded quite a bit, both in research and teaching domains. The latest addition is that we have established a Center for Excellence in healthcare, where the focus is on emerging technologies such as AI for healthcare. This is right now what we one of the research and development wings that currently looks like, right? So what do we do at our Center for Excellence and what do we do in our lab, right? So I'll start with what we have been doing in our lab, and then I'll give a brief introduction to what we have been doing at the Center for Excellence as well. In our lab, what we have been focusing on is what we call MedAIM, right? Meaningful, enriching, and discovery-led AI for medicine, right? So that's what we aim to deliver. Meaningful means that it should hold meaning for the clinician, okay? So or the public health or the policy maker. It should not just be a predictive model which basically does not convey strong sense of meaning to the stakeholders, right? So why I say this is because I see that a lot of models, for example, that are existing in computer science, they never make the connect with clinicians because they don't see a meaningful outcome of that. For example, physicians or policymakers may not care about models if they do not change their practice. All right, so or they do not change their policy. Enriching AI means that the meaningful AI solutions that we develop should actually enrich and come to their practice and come to their policy making. Discovery-led means that in our lab, we tend to lay a strong emphasis on knowledge discovery as opposed to just technical advances. So can we discover new knowledge for medicine? So that's what we call MedAIM. AM is AI for medicine. AIM is AI for medicine. So with that MedAIM philosophy, basically I'll be giving some examples on what are the different forms of AI in healthcare, right? And then how do they lead to contextual AI? Specifically, I'll talk about public health today. Okay, so the first form of AI that I would like to talk about, and many of you may have heard about many different classifications, such as supervised AI, unsupervised AI, reinforcement learning AI, right? But I would like to talk from perspective of data. So because any AI starts with data, right? So when you start making models, these models can be for predictions, or these models can be for understanding or for knowledge discovery. You start from data. So I've divided basically the session into AI for structured data, unstructured data, AI with no data, and then finally, how do we incorporate context into all of these, which is contextual AI. So we'll start with AI on structured data. All right. So the example that I would like to give here is our work from it's a supervised AI based approach that we implement in All India Institute of Medical Sciences, AIIMS, New Delhi, and we call it the SAFE-ICU project. This is an example of AI with structured data, mostly structured data, right? I'll show some examples where we also incorporate unstructured data as well, but so far we're working with structured data. How do we create meaning? So remember the MedAIM goals. The first thing that we did in this is that this is an ICU setting. So basically, I'm a Wellcome Trust DBT India Alliance Fellow at the All India Institute of Medical Sciences as well, in addition to my appointment as a faculty member of IIIT Delhi, which allows me to engage with clinicians at AIIMS New Delhi. And one of our very long-standing collaborations for more than, I would say, 10 years now is in the Department of Pediatrics. So when basically we were proposing this project, we asked the clinicians in the Department of Pediatrics that what is that one problem that you would like to solve if it were to be aided by AI, right? Because we wanted to contextualize. So the context will be very different for example, the US um, setting where the challenges will be different, the problems will be different, maybe different, right? Or if we were asking the question outside of an ICU, right, then it will be different. So within the context of the ICU in AIIMS New Delhi, the consensus was that sepsis, which is to be very simply defined, a bloodstream infection. It is one of the major killers in the ICU, right? Most of it's highly lethal. The mortality rate of sepsis in the ICU is in some cases as high as 90% in underdeveloped or less developed settings, right? In our ICU at AIIMS, it is about 60% mortality, which is again still a very high mortality rate. So it's a problem that they wanted us to solve. That if we can actually predict sepsis before it actually has its onset. Okay, so the problem that we were looking at is, can we really predict sepsis before clinicians detect it? Right, and that's why it became meaningful to them, because now basically they wanted uh, to be more aware of which patient may develop sepsis in the next, let's say, 12 hours, 6 hours, 3 hours, and so on. So we call this project SAFE-ICU. SAFE-ICU is an acronym for Sepsis Advanced Forecasting Engine, and this is one of the only projects in India which has, this slide is a little old, which now has more than 1.5 million patient hours of continuously monitored data on patients who have gotten admitted to this pediatric ICU at AIIMS. So the idea here is, as I say, to integrate all these. So idea is that whenever a patient, a baby or a child, gets admitted to an ICU, right? What happens is that they get plugged onto monitoring machines. These machines monitor the heart rate, pulse rate, oxygen saturation, respiratory rate, and so on and so forth. Right. So, and now with the advent of COVID, many of you may be also aware of such parameters such as the SpO2, which is oxygen saturation, which is very important, for example, in the COVID settings, right? So you monitor whether a patient is developing pneumonia by monitoring things like temperature and SpO2, etc. Right. So also these patients have a lot of other peripheral data sets that get generated. For example, the treatment notes that the physicians enter, right? The laboratory investigations that doctors ask for and their results, for example, blood tests. For example, hemoglobin is a very simple example that I think everybody here would understand. But then there is a bunch of blood tests, for example, arterial blood gases, biochemistry, serum biochemistry, culture sensitivity, and so on and so forth. And of course, the treatments. So our challenge was to integrate all these data in as non-intrusive way as possible. We did not want to impinge upon the workflows of the clinicians working in the ICUs, because ICU physicians are the most stressed. So again, the context asks us to develop AI, which more or less automates everything. For example, the data warehousing, the the model building, right? The signaling. It is a high it is a high intensity setting where basically we need to take decisions almost on an hourly basis, or maybe even on a in some cases in minutes, that what needs to be done on these children, right? So these data, by the way, are routinely generated in many ICUs, because across the country, across the world, ICUs, for example, this particular ICU of ours is an 8-bedded ICU. It generates about 1 gigabyte of data per day, right? But that is routinely lost. Bigger ICUs may generate more data, and those are routinely lost. So these are routinely generated and routinely lost data. So our first challenge was to really um, automate, as I said, all these processes, and where we built low resource pipelines, workflows, and also, for example, here you can see communication means to talk to these monitors, right? So to communicate between machines to collect this data without the need for a doctor entering it. Okay, so on the top left is an example where we used protocols that are used in medical informatics to communicate with machines. We created our own data warehouse, our own servers, which basically are housing these data. And essentially, then we get data from heart rate, pulse rate, oxygen saturation, respiratory rate, and so on and so forth. Why is this important? So commercial solutions such as Philips, for example, they so this is basically, I think, an old quote, but they charge about $3,000 per bed per ICU per bed per year in for data warehousing solutions. In this case, we were essentially doing this all for no cost, right? Just for the cost of what our project was. So this was important for low cost, low resource settings such as in India, and many of these solutions we have made actually open source for other people also to look at and use. So once we had these data, right? The challenge with AI deployment is that if we start building models, right? Clinicians may not trust our models. Clinicians may not even pay attention to our models or our data unless we actually establish the connect with clinicians. Again, context is important in that case, right? And meaningfulness is important in that case. So when we started out, we did not right away started building models with these. We started doing smaller things. For example, on the right-hand side, we built dashboards for the pediatric ICU, which says that what is the quality of data that we are getting. So for example, on the top left, there is a bar plot which shows which patient beds are having good quality data and which beds are having bad quality data. Good quality is in green, bad quality is in red. So what are the indicators of quality? For example, if the name entry is not correct, for example, the treatment chart shows a different name and the monitor shows a different name, that's one example of bad quality, right? Or for example, when we are monitoring oxygen saturation, the clip may come off, the oxygen saturation monitor clip may come off, and it may be giving a flat signal, right? Or ECG on the patient may be moving too much, and then the signals may be bad. So we created these dashboards showing data quality. We created dashboards showing antibiotic use, because that's what clinicians also care about. One of the things that they actually asked us to do is, can you tell us how much is the time that the baby is spending in the right oxygen saturation range? The child is spending in the right oxygen saturation range. Why is this important? If you give more oxygen, especially to preterm babies, and this was data from preterm babies, then it is dangerous. The right oxygen saturation range is between 88 to 95. Right, so 88 to 95%. If you go beyond 95% of oxygen saturation, the babies actually may develop something called retinopathy of prematurity, which leads to blindness. If you go below 88% of oxygen saturation, you are not oxygenating them enough, right? Basically, they are not getting enough oxygen in their organs. So the right range is between 88 to 95. And now with the big data that we were collecting, or in an automated fashion, for the first time, we could answer this question, and that's what the histogram plot on the bottom right of the screen shows, right? So you can see that there's a histogram. There are two blue bars. The two blue bars show what the right oxygen saturation range is, and the histogram shows whether the babies were in that range or not in that range. So now you can see that actually many babies were not in the right oxygen saturation range, and these led to some quality initiatives in our ICU, and also led to the publication which is listed below, which means that how do we target oxygen saturation amongst preterm neonates and oxygen delivery, and how do we improve quality using big data. Okay, so the message here is that, again, contextualizing your models. Right now, we are not even doing any modeling. We are just doing visualizations, and we are doing some minor modeling, some minor exploratory data analysis, such as histogramming or radar plots or quality checks. This is not even a model, but contextualize it and create meaning for what doctors want. After that, we went on to a real challenge, which was to predict. Right? Once we established trust with the clinicians, we started asking bigger questions that can we now start predicting, as we had earlier hypothesized, that can we start predicting sepsis? Can we start predicting organ failure? Can we start predicting shock, etc. Okay. And when I'm using the word predict here, it is different from how many computer science papers or machine learning papers use the word predict. For example, if I'm looking at an X-ray, right, and I built a model to 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 classify whether there is tuberculosis in that X-ray or not, or lung cancer in that X-ray or not. So many times we call it a prediction model, right? But in our sense of word, in the clinical sense of word, it is a detection model. It's a diagnostic model. We are diagnosing TB, or we are diagnosing cancer on that X-ray. We are not predicting anything in future. So that's a different sort. So we make this distinction very clear in AI for healthcare or public health, that are we doing diagnosis? Are we doing forecasting? Are we doing predictions, right? Are we doing prognosis? So these are very different things in the AI for healthcare settings. So in this prediction setting, what we are doing here is we're saying that if you look at the red line, it says disease onset, and this disease can be sepsis. As I said earlier, this disease can be shock, which is again another major killer condition in the ICU, right? And the black line, is the time, is the lead time, right? So basically before the red line, the gap between the red line and the black line is lead time. That is our window of opportunity that we would like to use to catch it early. That's why early prediction of sepsis using big data. And what do we look at? We look at data before the black line. Okay, so in very simple situation, what is happening is if I am a patient admitted to the ICU, my data is monitored for the next 12 hours, right? And then a prediction is given for next 12 hours, not looking at that next 12-hour data. Right, so that's the kind of scenario that we are doing, that we are having the red line when the disease onset happened. We have the black line where basically we say, okay, now is the prediction onset, and we look at the data before that. So that is the setting. And in this case, what we also do is we also contextualize our models with domain knowledge, right? So once we, for example, are building models, we would like to use domain knowledge also to create the context in which these models make predictions. Okay, so these help. I'll give you an example. So for example, an example of domain knowledge is one here. The one use case that I'm showing here is that what we did was we used thermal images as a predictor for developing shock, and this was never done before, right? So what we thought, and from our medical understanding, we know that one of the first things that medical graduates, when they're attending their clinical rounds, they are taught that hands and feet are cold in shock and abdomen is warm. Why does that happen? So shock is a condition when basically after sepsis, or mostly after sepsis in the ICU, what happens is that uh, the organs basically they start redistributing blood so that more important organs such as brain and heart and lungs get more blood so that they can survive, and less important organs such as skin, right, they receive lesser blood, right? And that is important because then basically it's an emergency response of the body to to keep providing oxygen to the more vital organs. This had never been tried earlier, right? And we thought that when we are building our models, we should be able to insert this domain understanding into our models to contextualize them. Okay. So we had a thermal imager, and what we did was we first did a sort of a manual exercise to see if our hypothesis was even correct or not. So here is an image of a child, right? And you can see that the thermal image of the child as they are coming out of shock. So left to right, basically the child is recovering from shock. Okay, and you can see that there's a difference in temperature or intensity or brightness between the abdomen and the foot in the leftmost image, and that difference is actually much less as the patient recovered from shock, right? So the graph on the right hand side actually shows that gradient of temperature, and this was manually first evaluated by manual evaluation using image processing software, right? Next, we automated this. Once we knew that this actually worked, we created artificial intelligence models. Okay, so what we did here was uh, we basically segmented out the body parts. So what we were doing manually first, now we actually automated all that process. Okay, so for example, you can see here that the baby's abdomen was segmented out by using computer vision models. The foot was segmented out using computer vision models. The gradient between the two segmented body parts was calculated, and that you can see that the ROC curves actually achieved more than 90% accuracy in these segmentation tasks. And then we fed these models into prediction models for 0 hour, 3 hour, 6 hour, and 12 hour shock prediction. Okay, and we were able to predict shock with up to 75% accuracy, even 12 hours ahead of time. So this is published. This was a small data set, but now we have actually followed it up with a much larger data set. The preprint is available online, but right now it is it's publicly available. You can go and read, but it's also under peer review, where we now have a video-based thing. Now we've made it made the same, extended this to a much larger data set where all this automated prediction is happening on a video basis, right? So on an ongoing basis. So also what we are doing is we are taking these to community settings where because these thermal image models are non-contact, non-invasive, so you don't even need to touch the baby, right? Because many times with smaller babies, actually they have thin skin, which leads to infections if you really put a lot of probes on them. When you take off a probe that sticks, you may introduce some breaks in the skin, which may cause then infections. So, so that is what we are currently doing. We are taking these models to the community settings where, for example, ASHA workers or mohalla clinics can use these models um, um, in a telemedicine sort of a scenario. Okay, I'll stop here before I move on to the next slide to see if there are any questions so far on this particular aspect, which is building contextualized AI models for ICU using computer vision. I'll pause here for a minute. And I would like this to be a discussion because then it would perhaps be a lot more engaging. And then I'll move on to the next phase, which is more on the lines of signals for predictions. So Dr. Radhika, if there are any questions, can you please read out the questions to me if there are any?
Participant, any question in chat box? There is no question.
Okay.
Participant, any question? Just you can unmute yourself and you can ask your doubt.
Yeah.
I think we can proceed, sir. There is no doubt.
Sure. All right.
Thank you.
So the other, basically, the challenge is that, okay, so far so good. We did this for one ICU settings at AIIMS, right? But the major challenge with artificial intelligence in healthcare is that we have to make models that are generalizable across contexts, right? So when I said that, okay, it is important for our context, but we cannot only make models that only work in our context, right? So we have to make models that can actually generalize across contexts. So I'm not sure if you are aware of the grand challenges of AI, right? And one of the grand challenges of AI is actually generalizability. And this is very true even for the healthcare setting, even more true, where if I develop something and that only works at AIIMS, what use it is, right? So you have to actually develop models which can generalize across contexts. So our work, again, this is available on medRxiv as a preprint, basically transcontinental shock prediction, real-time shock prediction in the ICU using vitals. So what we did here was we used deep learning to see if models that are learned on a very different setting, such as the United States ICUs, right? Can they be used? Can they be used to now port some of the findings and some of the predictions to our ICU, which is like the SAFE-ICU at AIIMS, and essentially then comparing how the accuracies actually change, right? So this was a model that was built upon a database called the Mimic database. Many of you may know it, or if you don't know, you can go and explore. It is a database from MIT Harvard collaboration. It is an ICU database, and it is an adult ICU database. So whereas the ICU that we work in is a pediatric ICU, so it is not only different in geography, it is also very different in the age structure of the population that we are looking at. Okay, so that's the second challenge that I wanted to highlight, that you have to contextualize models, but then you have to learn models that can also generalize across contexts. And what we find here, I hope I have a slide on that. I don't have a slide on that, but you can go and read the medRxiv preprint. What we show here is that using some novel representations of ICU data, which are again aided by domain understanding of how the physiological signals are. For example, if the physiological signals are fractal in nature, so we use something called Hilbert fractal space embedding. and these were fed onto deep learning models, and we showed that we actually achieved more than 10% improvement in generalization if we um, if we used our deep learning based approach versus if we just used a standard time series approach, which just uses time series features, right? So time series features are like mean, median, mode, standard deviation, variance, nonlinear features such as Fourier transform, chaotic time series analysis, dynamical system, all those features, which is a state of the art in time series analysis. So you were able to show that deep learning actually improved generalizability of the models across different continents. Okay, so again, making AI models that generalizes across contexts is something that if you are into AI for healthcare, you should definitely think about. Okay, so the next form of AI is AI on unstructured data. Okay, so everything that I showed before this was mostly AI on structured data. It was time series, it was images, right? Images are actually essentially matrices, right? So at the back end, an image is a matrix. You can treat it as a structured data and basically learn upon it. Similarly, time series are structured data, laboratory investigations are structured data. Structured data means that there are tables that you can, or matrices that you can work with. There are fields, and then there are values. Okay, standard structured databases that we work with. Unstructured data, one example is text. And in healthcare, one of the largest data sources is actually unstructured data. For example, the physician notes or the treatment charts. It's estimated that more than 80% of data in healthcare is actually unstructured in the form of text or in the form of, for example, linked text and images and so on and so forth. Doctors write a lot of things, but we never treat that as data. And that unstructured data actually provides a lot of context. I'll give you an example. Okay, if you are just looking at lab investigations of a patient, okay, the doctor will always ask you, please bring me the discharge summary. Okay, so let's say you are asking for a opinion of a doctor, right? So if you say that, okay, this is my blood report, HbA1c, DLC, whatever, and I'm having these complaints, please advise me. Okay, the most of doctors will say, please show me what your previous workups have been or what your discharge summaries have been. What are they trying to do? They're trying to look at the context, because a table, right, a blood value, for example, a diabetes test, an HB test, a blood sugar test has no meaning if the context is not there. Context means, for example, history of diabetes in parents, right? Or age, for example, right? And all those things, they all provide context. And most of this context lies in the text data. So now I'll give you some examples before we move on to healthcare on how this became really very important in biomedical field. Okay, so this is an example where last year a paper came out using showing that they were able to actually recreate majority of properties of materials as they are known in the periodic table just by building models on literature. Okay, so they were able to reconstruct the periodic table in a way. Okay, and they were able to predict the properties of materials on the basis of what the literature, material science literature talked about. Okay, how do they do that? Now this is again a field which is very related to both NLP. It's called word embeddings, right? So the title says unsupervised word embeddings, right? So these are also very much related to deep learning. because you may have heard about models such as BERT, right? Or now there is GPT-3. Okay, these are the models which, for example, Google uses when you are typing something in your search browser search. The auto completion that comes on your Google search is actually using a BERT model, a BERT word embedding model, which predicts that in the context of the words that you're typing, what can be your next words, right? So very, very heavily relying upon context of what you are writing, of what is present in the text. So what we did in our lab was in the healthcare space. We got inspired by these papers, and we thought that if AI, if models such as BERT can actually help predict some of these words, they can also help in, for example, uh, they can help in public health. Okay, they can help in providing public health interventions. So this is one of the projects that we initiated early on in this year. Actually, this project was running for about a year before we actually brought it to COVID. This is called WASHKARO, and WASH stands for water, sanitation, and hygiene. Okay, so we started this project in about mid 2019. And what we were looking at was that we were looking at the WHO guidelines on water, sanitation, hygiene. Okay, and we were running word embedding models on these guidelines, and then we were basically matching the similarities of these guidelines with what was happening in the news. Okay, our objective was that we wanted to deliver contextualized news, which is contextualized to WASH, to the right people in the right format. So for example, water, sanitation, hygiene is an important measure for preventing sepsis in in underdeveloped areas. Okay, even in Delhi, what we found was that the readmission rate of sepsis um, from the walled part of Delhi was much higher than the more developed settings in Delhi, which kind of gave us an idea that there may be socioeconomic factors, there may be education factors, right? And we wanted to target, for example, women, mothers in this case, because they are the ones who actually suffer the most if the baby develops sepsis. Many times, pregnant mothers die of sepsis during childbirth, right? So what we were trying to do was we were trying to use word embedding models to match these to create the right information. Okay, we did not want to just pick any news. We wanted to pick contextualized news, which was similar in space, in the word embedding space, to the WHO documents, right? Converted that into Hindi audios, right? So there was translation involved, and then there was also basically we converted it to audio speech, right? So the Google Speech APIs were used to convert it to speech, and for translation, Google Translate API was used. And what happened then suddenly when COVID came into picture, we thought that this actually is very important for COVID, because water, sanitation, hygiene, washing hands was the only measure that was perhaps known at that point of time, in addition to masks, when COVID came out in India. So ours was the first paper on the internet which said a machine learning application for raising WASH awareness in the times of COVID-19 pandemic. This was in March, I think it was March 16th, 2020, and we had just reported the first case of, India had reported the first case of COVID in Delhi. So WHO picked this, and basically this was presented at the WHO consult, infodemic consult, as one of the ways of raising COVID awareness or mitigating COVID misinformation. Okay, so a little bit. So this is how it actually worked. The WASHKARO app is still available on Google Play Store. Right now, we are not doing COVID anymore because in June 2020, Google actually came out with a policy that so many apps came out and many of these apps were spreading misinformation. So Google came out with a policy that only governments are allowed to release COVID related apps. So our app was taken off, but then we appealed. We said that our app was actually much before COVID. It was there on Play Store before COVID. It is a water sanitation hygiene app. So we just repurposed it to COVID, and basically it can be addressed. It can be used to address any other public health situation as well. So now we have a COVID. We have a WASHKARO TB app. Okay, which is focused on TB, and we intend to make it a more generic public health app. So the way it works is we used text summarization models using artificial intelligence, right? And as I said, we compared and generated similarity scores between the World Health WHO documents and news. We matched them, right? We translated them. We also incorporated user feedback. So if you installed our app, okay, you could actually give feedback on whether what you heard as a bite-sized audio in Hindi was actually relevant to you or not. Okay, so if yes, you give feedback as up or down. And then what we showed was actually this user feedback helped us to improve our AI engine. So we called our AI engine on air, and you could see that the relevant count, the graph on the left, actually started going up, and the relevant count decreased. Right. So this was one example where we were able to build AI system for better messaging for public health, right? And contextualized it by incorporating, for example, the daily news, by incorporating languages. Currently we are in Hindi, but we plan to expand it to other languages as well. And we delivered it in the right format, for example, by audios and visuals, right? So infographics, etc. But most importantly, if you look at the right plot, what we did see was that more females were engaging with our app in Hindi than males. Okay, and this was actually one of our first hypotheses that we need to reach out to females. We did not have any questionnaire on socioeconomic status here because that is we did not want to put any surveys which could impinge user privacy. So these were all anonymized surveys. We just collected gender information, age information, so on. So and that actually helped us a lot, and actually is encouraging from the standpoint of contextualizing your AI systems to the population that you are targeting. So we initially wanted to target mothers, right? We don't know how many of these are pregnant females, so we can't say that, but we were able to at least show that there was a difference in engagement. In general, more males were engaging, but more females were engaging in Hindi. Okay, so another example that we did in these COVID times, and I think that this will be the last example in unstructured data, is what we call COVID NLP. So this was again a project that started right when COVID started. Very fast-paced project, which students actually were able to finish in less than 3 months' time. It's still ongoing because we keep on improving our results on and on. I'll show some of those. But the idea was that when basically COVID literature is emerging, there's a deluge of information, and this information overwhelms any researcher or any policymaker, right? So when COVID started, there were papers saying that hydroxychloroquine is probably useful for COVID, right? Then there was a huge political debate, political discussions. Finally, we still don't know whether it is useful or not. But a lot of papers came out. A lot of papers got retracted. A couple of papers actually got retracted from journals such as Lancet. So there is confusion all around about COVID literature. Okay, so if you pick up a paper, you perhaps still cannot make out if you are thinking in the right direction or not. So we wanted to use our natural language processing models. Again, this is under review and is available for the public on medRxiv. The new version is getting updated in a couple of days because we update it pretty frequently. So what you can see is that what we did here is use the same kind of word embeddings as that paper for material science to ask questions like, okay, what are the new themes that are emerging in COVID across time? Okay, so if I picked a word, each dot here in this plot, sorry, you can go and visit the COVID NLP dashboard, it is public, but each dot here represents a word. And if you clicked on a word, it will show you what are the most related words to that word based upon our AI models, which are the word embedding models that we used. Okay. What it allowed us to do was it allowed us to actually track how these word associations changed over time. Okay, so for example, in March, maybe COVID and HCQS were more strongly connected. In April, it may have changed, right? And then so on and so forth. So we used our models to really understand network dynamics of these words, because you can actually think about each of these words connected to each other in a network. That's what we did. And now we, for example, here in this diagram, we see that how COVID actually emerged as a thromboembolic disease rather than just a respiratory disease. So on the left side, you can see and this is all data based. This is not done by any human intervention. On the left side, we have the word associations in March. On the right side, we have the word associations in August, right? And now you can see that a lot of word associations, small word associations came together. They became thicker. And when they became thick, they actually settle down, right? They become important and then they settle down into a module, into a network module of thromboembolism. Okay, so and this is the current understanding of COVID, that COVID now is not just a respiratory disease. Many people die of thromboembolic. It's a microembolic phenomena. Many people die of, many people have rashes, many people die of stroke, many people die of organ failure, and that cannot just be explained by just pneumonia. Okay, our model is able to capture all that understanding, and not only this, we are able to also predict what themes may emerge in literature. For example, we are predicting, and that's getting updated on the dashboard, as I said, in a couple of days. Just yesterday, we predicted that the emerging theme for February for COVID will be psychiatric issues. So we don't know if that will be how many papers come out in that, but psychiatric issues such as depression and all of that, which have not been a central theme so far, will become important as we go forward in the COVID literature. Okay, so that's one example that we are doing. Okay. Finally, in the last, let's say, 10 minutes or so, I will talk about the third form of AI, which is AI with no data. Okay, so we looked at structured data, we looked at unstructured data, and now we are looking at just simulations where we just give a policy, we give an objective. It's like I think many of you have played the game of Mario, right? So, and many of you have heard about something called reinforcement learning. So, so when you are playing the game of Mario, you want to maximize your score, right? And you want to also get to the end without dying. Right? So just as I'll skip this um, just for the sake of time. But for example, here is a model uh, that you can see on the right hand side, that how AI systems actually learn to play the game of Mario without any background data, right? By optimizing the reward that the Mario player uh, gets by doing a particular move. Okay, so we asked a question in this case for healthcare, right? So, but before we go to our question, I just want to say that reinforcement learning is very emerging. Okay, it is very new in the healthcare space. I think just in November of last month, there was a groundbreaking news that AI has now solved the grand challenge of protein structures, right? So this is a paper from, not a paper, this was actually a competition. This is a competition that actually is held every year, and Google's DeepMind has an algorithm which is called AlphaFold. Um, and uh, the new update of that algorithm is called AlphaFold 2, and that basically has in this competition, which is the CA SP competition, right? Critical assessment of protein structure prediction. They scored the highest, and not only they scored the highest, but the gap between them and the next algorithm is so huge that scientists said that basically AI has essentially solved the problem of protein folding. And how did they do this? They use similar reinforcement learning based paradigms. It's not open because it's a proprietary algorithm, but the AlphaFold 1 and previous versions actually used something using reinforcement learning, just like the Mario learns that a certain reward is good, right? So you learn a certain reward by folding a protein in a certain way, which gives the maximum reward. Um, Considering the physical properties of proteins. Okay. So yeah, so this is the paper from 2019 about AlphaFold 1. AlphaFold 2 paper is not out there yet, but this talks about reinforcement learning and deep learning. Okay, so the way we did this was actually we deployed it for public health settings. Again, this is a contextual AI problem. This is a problem that we are currently facing, that once COVID-19 vaccine comes out, okay, the challenge will be how to distribute those vaccines, right? So for example, now if you're a video game player, you want to distribute the vaccine in such a way that the pandemic ends in the earliest possible manner, right? So just to put it in a very simple way, just like that. Okay, so the paper is called Vaccine, Learning Effective Strategies for COVID-19 Vaccine Distribution Using Reinforcement Learning. Again, under review and preprint is available. We presented this at the MIT Vaccine Conference a couple of weeks ago. And what we are doing here is we are combining reinforcement learning model with a contextual bandit model. I'm not sure if most of you are aware of that, but these are two models. So one is like the Mario game playing model. The other model is a contextual bandit model, which says that, okay, you may be playing the game in the best possible fashion, but you also need to look at the context. For example, how many beds are available in this state? How many ventilators are available in the state? What is the proportion of susceptible population in the state? What is the death rate of the state, right? So that is the context. So we combined the reinforcement learning with the contextual bandit problem and showed that we can actually, this is right now in 5 states that the simulation has been done. We were able to show that more than 100,000 deaths, 1 lakh deaths could be prevented in a simulation that was carried out in August. So if the vaccine rolled out in September, and we were delivering the vaccine on 15th of September, in 1 month's time, September 2020, I'm not saying September 2021, September 2021, we were able to show that in 1 month's time, we will probably be saving more than, we'll probably be saying about 1 lakh new cases. Okay, if we took this approach versus a naive approach of wherever there is more cases, we distribute the vaccine there. Okay, so we are updating these models because we have actually updated the models, and we are updating the paper on the medRxiv because simulations have been updated. Vaccine has not yet been rolled out, so all that will happen. Again, this will be a freely available platform for researchers and policymakers. We're in fact actually thinking about collaborating, for example, with the US settings to actually roll it out for the US settings as well, just like something that MIT is currently doing. So this is again the contextualized AI approach to machine learning. All right, so it's 3 p.m. I think it's exactly right in time for moving into the next phase, which will be sort of a hands-on, a little bit of theory of what tools we have created. So I'll not go into these models because these are really, really complex models, and these cannot be really we can't train in, let's say, a session or so. These are like advanced AI models, but I would like to talk about a platform that is more accessible to beginning AI researchers. Okay, not even beginning to intermediate or even advanced. I mean, so if you look at our papers, most of our papers have used the platform which we call Wiser. It's a Bayesian artificial intelligence platform, and I will talk about it in the hands-on session. But I would like to take a 7 to 10 minute break right now, in which you can actually, I'll take a short water break, and you can also think about some of these things, think about questions. And once we come back, we will look at the next slides of contextual AI for Wiser, and essentially have the hands-on. All right, so I'll stop here for a bit, and with permission, I'll request for a 10 minutes break. Is that okay?
Yeah, that's fine, sir.
Okay, thank you so much. So it is 3. Yeah. It's 3:03 p.m. right now. Let's meet at 3:13 p.m.
Okay, sir.
Okay, so 3:13 p.m. Can you all hear me?
Yes, sir.
Yes, sir.
All right, so we'll start. I'll present my screen again and we'll get going. Okay, I believe you can see the contextual AI slide right now.
Yes, yes, sir.
All right, okay, so we'll proceed. So before actually, just wanted to make an announcement that one of my colleagues at IIIT Delhi, PK, I have his image on the last slide of acknowledgements. So he basically is leading one of the initiatives, and where I'm also mentoring from the healthcare perspective. It's called Anveshan Setu Fellowship. So if any of you who are PhD students here, right, and are working or are planning to work on healthcare, and you want some immersive experience, the kind of work that, for example, I've shown, you can have a full-time, part-time sponsored. You can have a sponsored sort of a visit to the faculty who are from multiple different institutes. They may be working on AI for healthcare. And it's a 4-week sort of arrangement where the host agrees and you agree, and it's done in the summer. So basically, students who are interested in working in AI for healthcare but do not know the domain and would like to get some experience or expertise in a short time of 4 weeks, there's an opportunity for a funded visit sponsored by the ACM India Council. Okay, so I just wanted to, and the deadline is January 31st. So if there are any students on that direction, just wanted to highlight this. Okay, so the next phase of hands-on, the background is that one of the ways you incorporate context into your models is by doing something called Bayesian modeling. Okay, so, and I'm not sure how many of you are aware of Bayesian modeling, but what I will do is I'll give you a hands-on walkthrough of what our Bayesian modeling platform is. So you'll, even if you don't know, you will understand. Okay, so the thing here is that in the real world, there is always a context. So for example, if I had asked you that if you see a car, what is the probability of seeing a wheel? Okay, you may give some number, you may give 70%, 80%, 90%, 99%, right? But if I asked you the opposite question, that if you see a wheel or if you hear about wheel, right? What is the probability that there will be a car in the context? Okay, and that will be a different number because wheels come with many other vehicles, right? It could be a bike, it could be a truck. So the probability of seeing a wheel when you see a car is not the same as probability of seeing the car when you see of inferring the car when you see a wheel, which means that most of the machine learning models that we actually use, they mostly rely upon associations, and associations are symmetric. Okay, so you may have heard the term that correlation is not causation and associations do not mean causation. So they are symmetric, whereas in the real world, there is always asymmetry. If you flip car and wheel, your probabilities will be very different, which again means that one way to incorporate context, and this is essentially the base of the Bayes theorem, these are conditional probabilities, right? So that what are you conditioning upon? Are you conditioning upon the ICU in AIIMS? Or are you conditioning upon the ICU at US? Are you conditioning upon vaccine being delivered to to a high frontline worker setting, or are you contextualizing it to vaccine being delivered to a low frontline worker setting? Okay, which means that the conditional probabilities can be used to exploit context, and I'll show how they can be used. Similarly, in medical situations, this is an example that I give to clinicians, that if you knew that a patient was on aspirin, okay, what would be your guess? That the patient is having coronary artery disease, right? This is a question that you can ask. The reverse question is, if you knew that the patient has coronary artery disease, what is the probability of them being on aspirin? And these probabilities are going to be different. Okay, so these are the kind of asymmetries that we explore in something called probabilistic graphical models. Okay, these are explainable AI models. So even, for example, we are presenting these models to clinicians, or we are presenting these models to policymakers, they would understand. Okay, so for example, these are in the form of graphical networks, but in reality they are models. They are not just networks. Uh, why they're models? Because then you can actually query these models. Okay, for example, here are the three forms of structures that you might find in a probabilistic graphical model. The first on the left side is called chain or a mediation effect. For example, smoking causes tar accumulation in the lung, which causes cancer. Okay, so it's a mediation effect where tar mediates the effect of smoking on lung cancer. Okay, and the way probabilities are handled in this effect are very different from the way probabilities would be handled in the right hand side graph. Okay, which is like the fork effect or the collider effect. You might have heard this term called confounding in a lot of statistical literature. Confounding is nothing but when you have a common cause, right? So for example, age also causes IQ to increase. Age also causes shoe size to increase. If you are doing a simple machine learning model, okay, or model which does not really take into account such conditional probabilities, your model may say that if you looked at shoe size, you can predict IQ. Okay, because with age, both shoe size and IQ are increasing. So if you are looking at data, and if you looked at shoe size, right, you actually can also make a prediction about IQ, which is wrong, right? Because shoe size does not predict IQ. It is actually age that is the backdoor variable that predicts both. So once you correct for age, or once you account for age, or once you conditionalize upon age, shoe size and IQ become independent of each other. So they don't have a direct link. Third effect is the collider effect, the bottom right effect, which says that it's different from the fork effect, where two things are pointing towards the same node. Okay, so for example, you went out and you saw that the grass was wet. Okay, now there's a possibility that, and you saw that the sky was cloudy. Okay, now you may think that it may have rained, or you may think that somebody had turned the sprinkler on. This is a classical example which is given in Bayesian reasoning. Okay, how do you decide whether the grass is wet because of rain, or the grass is wet because somebody turned on the sprinkler? So this kind of reasoning, this kind of effect, right, in our AI models is called a collider effect. And the way they change is, again, the probabilities change is very different. For example, I'll give you an example. As I said, that if you actually corrected for age in the fork structure, which is the top right, shoe size and IQ actually become independent. Okay, because age is a real causal factor. But in the bottom right diagram, if you conditionalize upon grass being wet, Okay, it will actually change it. The rain and sprinkler will actually become competing hypotheses, because now you observed the grass is wet. Now there are competing hypotheses. Now they actually become connected. Okay, now if you knew that the grass was wet, your connection, because if you didn't know that whether grass was wet or not, there is no connection between rain and sprinkler. Okay, it's 50-50 chance. Once you said, oh yes, grass is wet, now rain and sprinkler become connected because these are competing hypotheses. So they are competing for the same probability. Okay, so they become connected in the probabilistic inference. And this is what makes these kinds of models explainable and transparent. That's why they're also called explainable AI, and we like to use them a lot in our work because these help make the connect with clinicians and are contextual, right? So these are conditional probabilities, so they are contextualized models. Okay, so this was a paper that actually came out, our paper that came out in Lancet in 2015, Lancet Global Health in 2015, where we were able to show using these kind of models that if we were to increase LPG penetrance into the districts of India, okay, the rate of obstructive airway disease would actually go down by half. Okay, so this was a model that we did for all India settings. These were data collected all across India on 2 lakh patients on a single day. These data were collected by Chest Research Foundation, our collaborator in Pune. And we were just building AI models for them. So we were able to build these models. So you saw those 3 node structures. Now, if you put all the graph together, this graph, for example, here has this common cause, LPG, as a cause of obstructive airway disease and rhinitis and other things as well. So, which means that if we changed this, the rate of obstructive airway disease would actually change. Okay, and this was one of our first examples where we used contextual AI for public health. Then we actually thought that we should build a software out of this, and that's the WISE software that we will walk through, right? So recently we published a paper in the NeurIPS conference in the workshop ML4D, machine learning for developing countries, where we used similar approaches using our model to learn explainable interventions to mitigate HIV transmission. Okay, the question is that HIV spreads in sex workers very fast. What is that one thing that we should be doing that can actually mitigate the spread of HIV transmission in sex workers? Again, this was a work done in collaboration with an organization called Swasti. This is funded by Google. Essentially what we are looking at is that Swasti is the main, I would say the ground level organization that has been collecting these data for the last 15 years. We helped build the artificial intelligence models for looking at interventions. What we found was using our explainable AI Bayesian network models using Wiser, we found that financial literacy training, okay, so is the most important factor for predicting condom use in female sex workers. Okay, once we knew this and told them, they said, "Aha, we know this. We didn't think that this would come out in the data, but we kind of know why this would happen, because if women who are more financially literate, right, they know where to invest, how to save, where to save, and they are financially more secure, they feel more confident in saying no to unprotected sex and to use condoms." Okay, so this was what we found in the network, that this was the most actionable node, and we were able to use condom use and HIV testing, and we found that we were able to actually predict condom use on the basis of these variables as well. Okay, so this is also available online, accepted and published as proceedings for the NeurIPS ML4D workshop. So you can go back and look at more details. So I'm just providing some case studies of how these models that look at graphs, graphical models can help you. Last and final, this was published in the AAAI conference, which is a top venue for artificial intelligence. We looked at data from the US to ask the question that how can we mitigate health inequality in the US? Okay, and why did we use contextual AI for this? Because there are huge concerns about AI in the Western world. Will my AI discriminate against rich versus poor? Will my AI discriminate against the black people versus the white people, right? And so on and so forth. So we wanted our models to be contextual and explainable so that if a policymaker looks at those models, they are able to clearly see and use our models. That why are we predicting our outcomes, okay? So just to set the context, in America, the richest men live 15 years longer than the poorest men. Okay, so there's a longevity gap. There's also a longevity gap in the females. These health inequities, they lead to an economic burden in the United States. Okay, because people don't get adequate care, especially who are poor. There are very few who are rich. There are many, many more that they are not so rich. So this imposes an estimated burden of $300 billion per year in the US. Okay, so we asked this question, can we look at data from the US and look at what would mitigate, what does mitigate health inequality in the US? Okay, and we combined data from different factors like mortality, healthcare, health behaviors, education, demographics, socioeconomics like poverty, income segregation, social mobility, etc. Right, even things like religious adherence, all of that. Taxation, labor market conditions, okay, unemployment, all of that. And what we found was, I'll just give the key messages first, that more diverse counties in the US had lesser health inequality. Okay, now this was surprising to me because I thought that counties which are more diverse, when people immigrate into that into the country in US, right, more diverse counties may have more burden of illnesses because usually people immigrate from less privileged settings to more privileged settings, right? So I thought that this is counterintuitive, that more diverse counties should actually have more health inequality because there will be a diversity in Mexicans, Africans, Indians, Chinese, and that may have led to more health inequality, but that was not the case. So more diverse counties actually were 38% less likely to have the longevity gap between the rich and the poor. And our explainable AI model actually showed why. We found that more diverse counties, which is the percentage of foreign born node in this graph, had actually higher household incomes. Okay, and when we track back these chains, remember those chains in the graph, right? When we track back these chains, this higher income was actually traced back to higher earning females, a median house value and higher earning females. Here is the females that are in a proportion of females that are higher earning. In Q4 is basically the higher earning quantile. So basically more diverse counties have more proportion of females who earn higher than less diverse counties. And once you have the economic sort of equality, they get access to healthcare, so they live longer. Okay, so this is what we were able to actually infer from our explainable AI model. I'll just and then there's importance of primary care, which is already known. We were able to show that we showed that if you did a diabetic and lipid testing every year, that is the most important thing that you could do for improving healthcare in all the US. Okay. Similarly, inequality of the income and mortality. You can go back and read the paper. As I said, it's available online. So our software, which we're going to talk about now, also allows you to deploy your models as web applications. So what we do is most of the times we create open source software for people to deploy their web applications. Okay, so that you can actually not just use our software for understanding, but also for giving it to the public. Okay, so for example, this is an example of our dashboard that we made. It is called Longevity Gap Action, and it is available to the public. So I'll summarize the talk here, and then we'll move on to the hands-on. Okay, but to summarize, AI has a broad range of methods. We talked about structured, unstructured, reinforcement learning, and then finally contextual AI. Okay, structured AI helps underlying patterns. Unstructured AI can create new knowledge. Okay, reinforcement learning can help simulate some of the structures, some of the findings, right? And then contextual AI finally helps us make better decisions, because decisions have to be made in certain contexts. Okay, so again, I'll skip this. I've already told about this. You can enroll or apply to the program. I'll also acknowledge first before, so that I don't forget, all my lab mates who have been a part of all this work. They have actively contributed. A lot of this work is actually contributed by not just PhD students, but also a lot of bachelor's and master's students who are from IIIT Delhi and outside IIIT Delhi, essentially contributing to a lot of this work. So, and the bottom right image is PK, who is leading the Anveshan Setu program with the ACM Council, and PK is a collaborator on many of these works, especially the COVID works. Okay, so I'll switch gears now. What I will have to do is I will have to reshare my screen to software, so that you can have a hands-on view of what we are going to do. Okay, so I'll stop sharing. In the meanwhile, do you have any questions?
Participant, any question?
Okay, so
we can proceed for practical session, sir.
I'm starting the software. So it's an R-based software as advisor. You can, I think many of you are aware of the programming language called R. It is one of the very famous statistical and machine learning programming platforms, just like Python, because I don't know the background of the attendees here. So I'm just giving that. So you can install it from CRAN. And basically then you go to R, and there's a tutorial available on CRAN as well. You go to R and type visor, and it will begin. Okay, so I'm sharing my screen now. Okay, so just from my understanding, +1 if you know about R. Okay, so in the chat window, if you can just type +1 if you know about R programming language. Just for me to get an understanding of how many of you know the R programming. Doesn't matter, because we are anyways going to use the GUI, but it will help to know. So do we have responses in the chat window?
Yes, sir. We have one response. That one participant is aware about R programming.
Okay, and how many total participants do we have?
Right now we have 79. I think just 70 participants are present right now.
All right. Okay. So maybe not many participants know about R. So I would highly encourage those who don't know about R and you are thinking about computing for medicine or AI in healthcare, right? So the programming languages to work with are either Python or R. Okay. So we used R for this particular approach because the probabilistic graphical models have a better support in R. For most of the other works like deep learning and reinforcement learning, we use Python. Okay, so I would highly encourage you to, again, as I said, to really go use R, learn R, if you're serious about learning machine learning. Okay, especially in healthcare. In healthcare, even more important to learn R, because most of the times you will be asked to do more statistics, which has more support in R than Python. Okay, so so here is the page that comes up. as you can see, it is right now running on my local machine, on my local host, right? So I just called it from my RStudio, okay? And it opens up this home page. It says start analyzing. I press start analyzing. It will give you the option of, do you want to enable parallel computing or not? Okay, you can set the number of clusters and do you want to enable parallel computing or not, right? And once you've enabled that, they basically take you to the next step. Right now I'm not doing that because I'm showing you a very small toy example which does not need parallel computing. Okay, so then you go to the data. Okay, so now you can either upload your own data. For example, you can say that I can browse my own files, okay, in the CSV format um, to to upload data here, okay, or you can use some of the example toy data sets that we already have here. Okay, in this software, you already have loaded some toy data sets for you to learn. Okay, and you can upload your data in CSV, r.data, tab separated, space separated. You can't upload an Excel file. Okay, so you will have to work with a machine readable format such as a CSV format. Okay, so for the moment, let me just load the alarm data. Now basically it shows the alarm data has come up, and this is the data from the ICU. Okay, where the question is, will the ICU monitor raise an alarm based upon these variables? Okay, for example, central venous pressure, blood pressure, BP is blood pressure, total peripheral resistance is TPR, COA is cardiac output, so on and so forth, right? Oxygen saturation, oxygen flow, minimum volume of oxygen, and so on and so forth. And you can explore here. Okay, you can use the explore setting in this to explore the distribution of data. For example, CVP, these many patients had normal CVP, 72% patients had normal CVP, 11% had low CVP, 15% had a high central venous pressure. Okay, so this can help you in quickly understanding, for example, blood pressures, right? So only 24% of the population of the ICU population, this particular ICU, had normal blood pressure, right? 36% had high blood pressure, 39% had low blood pressure, which again, as I said, very common conditions in ICU are shock, which leads to low blood pressure, sepsis, right? All those lead to low blood pressure. So this was the dataset Explore. You can also pre-process, because here you can see that there are no numbers here, right? Now you may ask, what if I have data which is numeric? Okay, so this platform allows you to work with both numeric and categorical data, but the numeric data need to be discretized first. For example, a clinician may not want, what is my probability of diabetes if my blood sugar was 100.111 versus 100.112, right? So they want to know whether my blood sugar was normal range, high range, or low range, right? So that is what we did. But in the pre-process section of this app, you can do a bunch of things. You can convert. If you think that this variable is actually numeric, you want to convert it to numeric, you can convert those, right? If your data are missing, you can impute those data, again, using state-of-the-art machine learning based algorithms for data imputation. Okay, these are called MIS forests. These are based on random forests, and basically, and this wiser tutorial, so you have an app tutorial. If anything you don't understand, you can actually look at the tutorial, which gives you the details on how we do the imputation. You can read for some of the things that I talked about on the different effects, right, and the different functionalities, etc. Okay, so let's go back to the data. You can discretize, right? You can transpose your data. You can arrange and sort your columns. You can delete some variables if you don't want some variable to be present, so on and so forth. Most importantly, you can specify intervention variable. I don't think we'll have the time to go into an intervention variable today. It's an advanced topic for causal modeling, which we are not covering today. So I'll just be covering the contextual side of things and not the causal AI side of things today. But just for you to know that we can also do causal analysis with this AI platform. OK, and at any point of time, once you, for example, have processed the data, you can download it. OK, it'll allow you to save it in a CSV format as well. All right. So next, I'll skip the association network because that's something which is not AI. That's just associations, as I said, right? And let's just build the associations for. OK, let's say if I had 60% probability, what are the associations that get crossed at 60% probability, right? Okay, so this is the association graph for there's a small toy data set, large graphs, as I said, as I showed in the presentation. They are, and our research studies are usually larger graphs. But for example, these are the associations. Notice one thing, that these associations do not have a direction. OK, so I can change my threshold. This is all about above 60%. If I had lowered the threshold of association, I would probably get more links. OK, but do I want to do that? Probably not, because we want more we want more confidence, right? So if I, for example, decrease this, now you see when I decrease it, your graph actually gets more connected, right? Because now my threshold is so low that things are getting connected with each other much more often. When I go high, right, they don't connect as much. OK, but this is not the most interesting thing because this is not a model. First of all, what we are doing is we are looking at pairwise associations, and these don't have any direction. So you can't do any of those probabilistic changes that I talked about, mediation, collider, and all of that. OK, that's why we go next to Bayesian network. OK, now this is the most important part, and I don't think, since Bayesian networks and probabilistic graphical models are such a deep subject, I don't think we'll be able to deal with everything, but I'll just give you a walkthrough. OK, the most important thing in the Bayesian network analysis is structured learning. OK, now in this, you have the option to say that, for example, if you remember that smoking causes lung cancer. So I can initialize my learning with prior knowledge, with medical knowledge, with public health knowledge, right? You can do that by either saying, OK, I already know that there's a direction from smoking to lung cancer. In this case, let's say from CVP to PCWP. OK, and then I can add another, say that PCWP to, let's say, HIST. OK, I can add that. So think of this as CVP to PCWP, PCWP to HIST. OK, so like smoking causes tar causes lung cancer. OK, you can either do this, or if you have a large list which is automated, which is the kind of work that we do most of the times, we just upload an edge list as a CSV file that these are the prior known edges, and we just upload it by using this button. OK, again, we can remove all of this. Or I can reverse this as well. OK, so select from table. There we go. OK, so now we were able to remove these because I don't know if this was correct. Then if you don't have any initial knowledge, this is optional. You don't need it. You can go right away to learning of the structure. OK, again, as I said, it is a deep topic. There is a 1200-page book by one of the Stanford colleagues, Daphne Kohler, who basically also has a Coursera course on probabilistic graphical models. OK, you can refer to that course, or you can refer to the book by the same name called Probabilistic Graphical Models. And and learn about all these different settings. What is hill climbing? What is taboo search? But okay, but default settings which we are saying, we also given recommended settings. These are default settings which are usually the best way to go about. Okay, so if I go by hill climbing algorithm, Bayesian parameter estimation, a default network scoring method called Bayesian information criteria. Okay, and I just say one-time learning. Right now, I'm only learning one-time network because otherwise, I'll give an example. What is the difference between one-time and bootstrap learning? Okay, so now you can see that I pressed on one-time learning. Now it gave me a model. Okay, and when I zoom into this model, now you can see that there are arrows. Correct, and now this is different from the previous network because since these are arrows, now we can actually start playing with probabilities. All right. So for example, what if TPR is, we can ask this network, you go to inference learning, which we cannot do with association networks. We can say that, what if I know that BP is high in my patient? Okay, let's say BP is high. What can I infer about TPR? TPR is total peripheral resistance. Okay, then you can say with and without error bars. Let's just do without or with error bars right now. It'll give you the probability that if your patient is having high BP, the probability of having TPR in the normal range and high ranges are higher than probability of having a low TPR, which makes absolute clinical sense. Remember, I have not told anything to the model. If I am not a clinician, I will not even be able to understand what is happening. But I know that if peripheral resistance is higher, right, BP cannot be low. That's what it is saying, that if peripheral resistance is higher, right, BP or if BP is high, peripheral resistance cannot be low, right? So it cannot be low in this case. So this is the advantage of using these kinds of models for understanding our data. Now, but this is a network that we learned only one time. Okay, how confident are we on this network that this is correct? To do that, we do something called bootstrap learning. And again, bootstrap is a very common method used in machine learning and AI. Okay, where what we are going to do is we are going to resample the data. We are not going to use the entire data. We are going to take a part of the data by something called bootstrapping. It is called sampling with replacement. And we are just looking at a sort of a sample of the data, building a network, looking at another sample of the data, building another network, and another sample of the data and building another network. And then what we do is we ask these networks to vote. Okay, so that is called ensemble averaging. So for example, here I can say that, okay, I will learn 11 such networks, bootstraps. You can set it to be whatever number we want. We always set it an odd number so that there's always a majority winning. If 5 say yes, 5 say no will be a problem, right? So for majority criterion, we choose an odd number of bootstrap iterations. And then we say that there should at least be a majority in favor of the model that we are finally going to see. At least a majority. It can be higher. You can set the confidence to be higher, maybe 90%, but at least a majority is usually what we go with. And then we say, okay, learn the bootstrap. Now it'll take more time because instead of one, we are learning 11 structures. And this is where parallel computing comes in. If you are having access to a cluster, each of those models will be running independently on different nodes of the cluster. And so essentially you will finish in a parallel time, right? So I think it'll take maybe 30 seconds more. Meanwhile, please be ready for the questions. We'll spend the last 5 minutes on only questions. Okay, so there we have the structure. Now you see that it is a much sparser structure because not every link crossed the threshold of majority voting in the 11 networks. Okay, Then basically you can see that did the link with BP still remain? Yeah. So BP and TPR still have the link with a confidence of 100%. All 11 networks voted that this link is present. Okay. This is also one. Most of these are actually one. So this is a very strong sort of a structure that we are able to learn. Okay. In general, in real life data sets, because this is a simulated data set, real life data sets, for example, here you have, I saw 0.818, right? This is, for example, 0.818. So in this, you are able to see some variation in the strengths. Okay. But most of the network, almost all the 11 networks said that, yeah, this link and this direction are present. Okay. So that was it. And once you have this, you can then basically you can, as I said, you can do the same thing there. As I said, okay, what is, if I knew that BP in this patient is high, what can I say about TPR? Right, and I can say with error bars, right, and you get a similar result as before. That is, as if BP is high, TPR cannot be low. Okay, there's very low probability that TPR can be low. It may be normal or it may be high. Okay, but it cannot be low. So those are kind of things. And so as I said, I cannot give the full walkthrough. So these are other things such as decision network, but these come in the domain of decision AI, which needs something called causality, which I said cannot be dealt in such a short time. So I just wanted to give you a walkthrough of what the basic sort of modeling with Bayesian artificial intelligence for contextual AI is about. Okay, then you can publish your dashboard. You can look at the app tutorial to know more. Okay, so that's it. 3:55. Let's have questions in the last 5 minutes.
Thank you so much, sir. Participants, you can raise your questions.
Sir, you have referred to AI without data, where you highlighted about reinforcement learning. Is it that reinforcement learning is more appropriate when the randomness of the event is much higher?
Not necessarily. So reinforcement learning is more appropriate when actually you are doing simulations. Okay, so if the randomness of the event is much higher, you probably will look at more statistical approaches to, for example, stabilize the variance, or to or to um, or to look at some of the methods which actually select variables which are less random and are able to really contribute to learning, right? So it is not so, when I said without data, I did not mean that you remember, reinforcement learning is a very, very difficult problem. So it cannot be so that if you don't have data, let's do reinforcement learning. No. Reinforcement learning is for the situation where you know that there is some reward that you want to maximize. So there's some action that you want to take, and there's some reward that you want to maximize. So if you have that scenario where you have a set of actions and you have a set of rewards, okay, because usually in analysis we don't say that, okay, I have these actions and I have a reward to maximize. So we don't do reinforcement learning. But if I have actions, for example, give 10% of the vaccine to Delhi, give 10% of the vaccine to Bihar, let's give 30% of the vaccine to Maharashtra. That is the action space. There's a reward that if this happens, what is the reward in terms of how many new COVID cases do we prevent in the next 60 days? So not every problem we'll be able to formulate in an action reward setting. So reinforcement learning is for the settings where you don't have data, but you have some understanding. You formulate the action space, you formulate the reward space by yourself. Okay, there's some principles of doing that, and let the computer learn. Okay.
But sir, understanding the physics of the problem would help me to do it better, I believe.
Yeah, absolutely. Not every problem. Absolutely, you are absolutely correct. So if you, and that's machine, for example, the Mario game playing, they incorporate physics of the problem as well. So absolutely.
Thank you, sir. Thank you.
Any other participant? I guess that's it. Okay. So thank you so much, sir. Thank you for your valuable time. And believe me when I say these words that we have had so many, this is the second slot of the STDP we are conducting. And we have had great speakers who have helped us too much. But when it comes from a person who has already had a degree in medical, it's altogether a different charm. Your understanding and the way you could give us real world examples for each and every topic, I don't see there can be anyone else who can explain AI for healthcare better than you. And it's so fortunate that I could come across such a great personality like you, invite you, and it was so kind and grateful of you to accept our invitation and join us for the session on such a short notice. I'm truly honored, sir, and obliged to have you, sir. Thank you so much. And I'm sure the
Thank you.
participants had a great learning. And we would want more of interaction with you and learning from you in future as well, sir.
Look forward to. I'm humbled by your thoughts, and I look forward to engaging more. Thank you so much.
Thank you, sir. Thank you so much once
Thank
again.
Thank you.
Okay, thank you so much, participants. I see we have a little lesser number right now. So please ensure you're being present for all the sessions as required. And I hope you're really having a good time learning the STTP. Is there anything you want to share with us at any moment? We would be happy to hear. And please join tomorrow morning session. We shall start at sharp 9:45 tomorrow. We are starting it a little early because of certain, preponements for the afternoon session. So please be there at sharp 9:45 a.m. tomorrow for the 5th day of STTP. Thank you so much. Have a good day. And we really feel great that when we read the comments in the chat box that you had a good session. Thank you.